your group and where you are located at the moment into the chat. Please keep yourself muted. If you've got a question that can wait till the end, please put that in chat and we'll look at that towards the end of the call. If you've got anything that you want to ask there and then, raise your hand and we'll call on your name. So I will now hand over to Dr. Karen Moshel, who's a consultant in infectious diseases at Great Ormond Street Hospital, and we're going to be looking at diarrheal disease in children. So I'll hand over to Dr. Karen.
Hi everybody, and thank you for the invitation to speak. It's a pleasure to be with you today. I'm going to take you on a whistle-stop tour through diarrheal disease in children. And what I plan to cover in this lecture is the epidemiology of diarrheal disease, so you understand when you come away why it is so important, the pathophysiology of this, the causes, the clinical presentations, some of the public health considerations, and preventative measures that can be taken in order to decrease the amount of diarrheal disease and prevent it. So you should come away from this lecture with an understanding of the disease, how to approach it, and a systemic approach to a child with diarrheal disease. So let's talk about epidemiology. Why is this important? And it's important because there are about close to 2 billion cases of diarrheal disease worldwide every year. And of those cases, there are 750,000 deaths, mainly in the under 5 age group. And of these, 750,000 of those, 500,000 are occurring in the first 2 years of life. So it's a hugely, hugely important subject. About a quarter of these diseases occur in Asia and a further quarter in Africa, with the remaining half across the rest of the globe. However, 50% of those deaths from diarrhea occur in sub-Saharan Africa. So we're going to look at some of the preventive measures that have allowed other parts of the world to be successful in decreasing deaths. About a third of these severe episodes can be prevented by vaccination. So if we put this into context, let's put causes of death of children under the age of 5 into some kind of context. And you can see that diarrheal disease actually is a huge chunk of this. So if we can decrease that, we can significantly impact under 5 childhood mortality. And those of you who are looking at this closely will notice that this is a relatively old slide and old statistics from the beginning of the century, but unfortunately not a great deal has shifted in that time, which is something that hopefully we will be able to do in the future. So let's start with the definition of what actually is diarrheal disease. And this is the passage of 3 or more loose or liquid stools per day. Now, those of you who have children or who are around babies or who have been looking after babies will know that many of them will have far more stools than 3. So how do you differentiate between what is normal and what is pathological? And the way you do this is to look at the frequency of stools compared to what is normal for that child. So babies who are breastfed can have anything from 1 stool every 10 days to 1 after every feed. And so it becomes quite difficult to differentiate. But if you ask the parent or the caregiver, they can be very clear about what is normal for that child, and then you can assess whether this is a deviation from that. But in general, in older children, 3 or more loose or liquid stools a day is a good benchmark. Now, what actually is diarrheal disease, and how do you differentiate where that disease is coming from? And I divide it into 2, into small bowel disease and large bowel disease. And it is quite easy clinically to determine whether we're dealing with small bowel disease or large bowel disease. And I can hear some of you saying, well, why is this important? And that will become clearer as we move on. So when we're looking at small bowel disease, the volume is large, so there's a lot of diarrhea. There isn't really any pain associated with it, and there isn't any exudate. And by that I mean you won't see any mucus in the stool, and you won't see any red blood stools in the stool. It is just the passage of large volumes of liquid fluid. Large bowel diarrhea is quite different. You don't have that much volume of fluid. You have a lot of pain associated with it. You have mucus, which are your white cells, your exudate, and you might see blood in the stool as well. So those are two very, very different types of disease processes. Now, why is this important? Now, diarrheal disease is a process of the gut lumen, and it's processes that happen at the surface of the gut, and in the surface, the layers, different layers of the gut. So when you look at the small bowel, you have an increase in the amount of fluid that is being excreted into the bowel, and you have a decreased absorption of the fluid that is coming into the bowel. So any fluids or foods that are swallowed and ingested by your patient will start to be absorbed in the small bowel, but when you have diarrheal disease, that is not happening, and therefore it goes straight through. So you have fluid loss. And you have fluid loss both because you're not absorbing and because you might be secreting into the gut and increasing the fluid volume. And that causes dehydration. The large bowel, however, you have an inflammatory process. So you have diarrhea, but you also have an inflammation on the surface of the large bowel, which is what causes the mucus and the blood. And therefore, because the volume is less, you have less dehydration. And actually, if you think about it, most of the absorption of fluid happens in the small bowel. So by the time you get to the large bowel, there isn't a great deal of fluid that is being absorbed from there. And that's why another reason why you have less of a problem with dehydration. So what does this cause? Now, when you take in fluid and when you lose fluid, in general, you're in balance. So you take in fluid through food, through water, and through breast milk. You then lose fluid through urine, through stool, through sweat, through breath, and through your GI, gastrointestinal tract secretions. And in the normal course of events, your normal intake is equal to your losses. However, with diarrheal disease, your fluid loss is greater than your intake, particularly obviously in small bowel disease, and therefore the net result is dehydration. So, dehydrated, you start with a loss of water. You then have a loss of electrolytes. You then lose the extracellular fluid from the cells. Once that happens, you start to lose your intravascular fluid, which results in a loss of your blood volume. And when your blood volume decreases, your heart increases its rate and you get tachycardia in order to make up for the lower blood volume. Once that can't keep up, once your heart rate can't keep up with the decreased blood volume, you then drop your blood pressure. And once you drop your blood pressure, you are not providing your organs with enough blood perfusion and circulation, and you then have you go into organ failure. So it is a cascade that starts with a minor problem, and if allowed to run, will end up with multi-organ failure. Now let's shift to what actually causes that pathophysiological process. Now, you divide the causes of bowel disease into infectious causes, post-infectious causes, and non-infectious causes. I'm going to concentrate in this lecture on infectious causes. However, to give you a complete picture, you need to be aware that not all of them are infectious in nature, but you'll have a good understanding of which ones are and how likely it is. Now, when we think infectious causes, the majority of them are going to be viral. We'll have bacterial causes and we have parasitic causes. And I'm going to talk you through the most important of each of these over the course of this lecture. You then have a post-infectious diarrheal phenomenon, which I will elaborate on. But essentially, because the gut has been damaged, it needs to repair itself in order to function properly and absorb fluids properly. So even once your pathogen is gone or your cause of diarrhea is gone, the gut still needs a period where it recovers so it is then able to absorb your fluids as well as it should. And then you have non-infectious causes, you have inflammatory diseases, inflammatory bowel diseases, and you have medications. And I'm not going to talk any more about either of those. So let's talk about how we classify diarrhea. Now, acute watery diarrhea, which as we've established is small bowel diarrhea, is usually viral in nature. And as with everything in life, there is an exception, and that exception is cholera. And I'll talk more about that so you understand when you're going to see it. Acute bloody diarrhea, which we call dysentery, is usually bacterial in nature. And of those, the most important are Shigella, Campylobacter, and E. coli. If you do not have an infectious cause for your acute bloody diarrhea, you do need to think about non-infectious causes. And then you have persistent diarrhea. The causes are post-infectious, which is common, HIV, which in parts of the world is common, and it's important to remember this if you have persistent small bowel watery diarrhea, and then you have your non-infectious causes. So let's break this down into its parts and look at the most important viral causes of infection. So this is going to be the majority of small bowel disease, which is watery diarrhea, and the majority of the diarrhea that you will see. And of those, the most important causes are rotavirus, norovirus, and then others such as astrovirus and adenovirus. And you can distinguish certainly rotavirus and norovirus from each other. Norovirus is a quite spectacular virus, which is very infectious and tends to occur in outbreaks. It's famous for causing disease on cruise ships and ruining people's holidays, and closing down more seriously wards across hospitals, particularly pediatric wards, because it is incredibly infectious and will spread like wildfire, and it causes acute watery diarrhea. Your bacterial causes are E. coli, Shigella, Campylobacter, Salmonella, all of which cause large bowel disease, which is dysentery, and then our exception cholera, which causes large volume watery diarrhea, i.e. small bowel diarrhea. We then get parasites, the most common of which are Giardia lamblia, Enteromoeba histolytica, and Cryptosporidium. And then we have worms, which can cause a more chronic, persistent diarrhea in children. So now, it doesn't matter what the cause is. We can talk about them, but what is the actual implication for our patients? And the answer to this is yes and no. Why? For individuals and case management, it doesn't really matter. And as you can see, and I hope you're starting to see now, it's quite simple to classify your diarrhea and have a really good idea of what's causing it without doing fancy diagnostic tests. And the treatment is symptomatic for the majority of them. Now, we will talk about those that need treatment, but again, the treatment, the antibiotic treatment for infectious bacteria and bacterial disease is common across the different causes, bacterial causes. However, it's very important epidemiologically to know what the most common causes of disease are, where they occur, why they occur, what time of year they occur, so that preventive measures can be put in place to decrease the burden of disease, and also to anticipate it so that it can be treated as quickly as possible. Non-infectious causes are going to require different management, and need to be recognized. However, you would only look at this once you have excluded an infectious cause. So let's quantify our diarrhea. What are the most important causes? And 28% of severe cases and 28% of fatal cases of diarrhea are caused by rotavirus infection. So 50% of the infections that are going to cause us most problem are caused by rotavirus. Now, these are bacterial infections. These are viral infections. Only 1% of severe small bowel disease is going to be caused by cholera. Although cholera is, of course, our most spectacular disease. It's the one we hear about. It's the one we see in areas of conflict. It's the one that we see in refugee camps. And it's an important one because it causes a great deal of disease and spreads very, very quickly and is incredibly dramatic. What is important about these two, one viral and one bacterial, is that both diseases are vaccine preventable. So let's talk about rotavirus, because this causes the majority of vaccine preventable diarrheal disease. It's a double-stranded virus, and there are 7 different antigenic groups, with group A causing the majority of disease. And it is species-specific, so we see it obviously in humans, but cats and dogs and cows will also get rotavirus infection. It's endemic worldwide, and it occurs mainly in the winter and early spring in temperate climates such as Europe and North America. In the tropics, you'll see it year-round, and that's quite important when you start seeing diarrheal disease towards the end of winter and early spring, because you already can have a very good idea without any further information as to what's causing it. It can be found in the stools for days before onset of clinical disease, which makes it then difficult to prevent clinically, and it can be shed in the stool for days after the illness seems to have disappeared. And that is particularly problematic in children who are immunocompromised, because children who are immunocompromised can actually shed rotavirus for months and months and months, which tends not to be a problem for them once they've recovered from the acute illness, but can be a problem in terms of infection control. It's found on fomites, on toys and on hard surfaces, which is why cleaning is so important, and cleaning with disinfectant and ethanol solution will solve that problem. So therefore that is a very crucial part of preventive processes. It has an incubation period of about 24 to 48 hours, and it starts with fever and vomiting. So you will have a day or so of fever and vomiting before your watery diarrhea kicks in. And that can cause clinical problems, because you're going to start dehydrating with fever and vomiting, and then that's going to be exacerbated by your watery diarrhea a couple of days later. It usually lasts 3 to 8 days, and you can get electrolyte imbalance, dehydration, and acidosis. And obviously this is most problematic for the younger children, which is why the mortality rate in that age group is so high. You tend to diagnose it clinically And any nurse or doctor who's an experienced pediatrician who spends a lot of time either in community clinics or on wards will recognize rotavirus immediately because it has a very distinctive, very awful smell. You can diagnose it using PCR tests or immunoassay tests, but most of the time this is not necessary. You would need it potentially for infection control reasons on hospital wards, but from a completely practical point of view, if it happens in winter, early spring in Europe, if it is small bowel diarrhea, watery in nature, with this clinical presentation, and there are other kids in the community with it, it is almost certainly going to be rotavirus disease. And our treatment is purely symptomatic, which is replacement of fluid and replacement of electrolytes.
Sorry to interrupt you, Doctor. We've got a question. Can we use hydration techniques in this case?
Yes, absolutely, and I'm going to talk you through those slightly further along in the lecture. Cholera. Let's just talk about cholera because that's the other important small bowel diarrheal disease, and it's caused by a bacteria, which is V. cholera, and it's a gram-negative bacteria. Outbreaks are caused by toxin-producing serotypes, which are found in contaminated water and food, which is why it's found in conflict situations and in overcrowded regions and in refugee camps, because there is a breakdown of sanitation or problems with sanitation in those areas. It is a massive, painless diarrhea, and it leads to severe dehydration because of the volumes, and with that massive electrolyte loss, you get your hypovolemia, you lose glucose, and you then become comatose, and death follows. Now, like all other diseases, this is a spectrum. You get milder ends of the spectrum, and the most important thing with cholera is making sure that you keep up with the hydration and with the electrolytes. And if you do that, and you can prevent your electrolyte imbalance and you can prevent your hypovolemia, you won't lose your patient. So it usually lasts for 3 to 7 days, and in many of them will be mild to moderate disease. But it's important to recognize, because you want to make sure that from an infection control point of view, you are not allowing those people to spread it. Can be treated with antibiotics, and the best one to use would be a fluoroquinolone, ciprofloxacin. And when we talk about other bacterial diseases, you'll understand why it's a good one to use here too. Now, let's talk about large bowel diarrhea. Shigellosis is a good example of this. It is, there are a number of different subtypes which can cause it. And what's important is you don't need a large number of organisms to cause infection. It causes a colitis, so that is an inflammation of the large gut wall, and you get bleeding of the mucosa, you get white cells, red cells, and because it's large bowel and most of the absorption we know takes place in the small bowel, dehydration is not a problem, but fever, abdominal pain, weight loss, lack of appetite and not wanting to eat are all symptoms of this. It is an invasive bacterial infection and is important to treat it with antibiotics, and fluoroquinolones are the drug of choice. It has a high mortality if you don't treat it, and again, this tends to occur in outbreaks with person-to-person spread. So we've talked about important causes of large bowel disease and small bowel disease, and we're now going to talk about risk factors for severe diarrhea. And when I talk about this, this is really focusing on small bowel diarrhea. The peak is the 6 to 24 month age group, and the reason for this is that that's the time you start to wean and babies get exposed to foodstuffs and which are potentially contaminated. They start to move around to put things in their mouths to socialize, and they're being weaned off breast milk, which is the most sterile food that you can give them. Undernourishment is exacerbates diarrhea and can be exacerbated by diarrhea, and zinc deficiency and vitamin deficiency are also risk factors. So what do we look for when we're looking to see clinically if a child has diarrhea? We're looking for symptoms of vomiting, increased numbers and looseness of stools, smelly stools, and children who are off their feeds. So that's what your caregivers and your parents will come to you with. When we look at signs, we're looking for fever, we're looking for lethargy, and we're looking for dehydration. Now, I'm going to talk a little bit about how we recognize all of this, because it can seem quite daunting if you are inexperienced. And one of the most wonderful tools is the IMCI tool, which is available both on the UNICEF and WHO websites. And it's a tool which assists in recognizing children who are sick. So it gives general danger signs, major symptoms, and a prompt to look at nutritional status, immune status, and feeding problems, which identify the majority of important and common illnesses. And this is a really useful system to use, even if you don't use it formally, to keep it as a system in your head. This is an example of it. You start looking for danger signs, for unconsciousness, irritability, and vomiting. You look for diarrhea, and you look at the nutritional and immunization status, and you classify them as extremely unwell, needing to be seen acutely in a big hospital. Yellow, moderate, can be managed as an outpatient, or green, they're okay and the parents can manage them easily at home. So what do we look for? We want to define the degree of hydration, either it's mild or minimal symptoms or signs. Moderate symptoms are thirst, irritability, restlessness, decreased in skin turgor, I'm going to show you that, sunken eyes, and then severe signs are all of those more marked, but also a decreased level of consciousness, an inability to drink, rapid pulse, so you've got tachycardia, decreased urine output because they are conserving water as much as possible, and pale skin. And again, I'm not going to go through all of this in the interests of time, but this, again, is a good tool for quantifying and classifying how big a problem you are dealing with. So how do you recognize signs of infant dehydration? Now, at the top of every child's head is a sunken spot, which is the fontanelle. That normally feels firm. You can perhaps just feel the edges of the bone around it, but if your child is dehydrated, that is sunken in, and you can feel the edges of that bone very, very prominently, and that tells you that child is dehydrated. The eyes will look sunken too. You then look at skin turgor. Now, normally, if you were to pinch the side of the skin on the belly, it springs back into place like an elastic band very quickly. But if you don't have much fluid in your system and you are dehydrated, when you pinch the skin, what happens is it stays pinched and it takes time to spring back into place, which is important in recognizing dehydration. And the longer it takes, the more dehydrated that child is. These are pictures of children with sunken eyes, and as you can see, none of them look particularly well, and all of them look lethargic. So how do we manage it? And this speaks to the question that came up a bit earlier. You want to characterize and classify your dehydration. You want to determine how bad it is, and then you want to start to rehydrate that child. And you want to continue to maintain hydration, because if you do that, whatever bug is causing it, and we're talking about viral disease now, will look after itself. And again, this is small bowel disease with large volumes of fluid. Normally, routine school stool culture is not needed. It's impractical in a lot of places. If you're in a big teaching hospital, you might want to know for infection control points of view. But if you're in a community setting, it's relatively clear what you're dealing with and how you need to deal with it. So outside of epidemiological reasons, you wouldn't need it. If you have bloody diarrhea and you're looking at a large bowel dysentery, then you certainly would want to culture the stool. However, you would use the same antibiotic. You'd use ciprofloxacin, so you wouldn't need to delay treatment while you were waiting for the result. We treat with oral rehydration. So in infants and in babies, we're talking about breast milk, and then we're talking about fluid replacement, which you can do with breastfeeding, or with NG tubes in more severe cases when the baby will not take fluid orally, and only as a last resort would you use IV fluid. Now, what is important to remember is that you can use NG tube feeds even if your baby is vomiting. And the reason for this is because your tube is going down into the stomach and it is bypassing the gag reflex. And very often, if you do that, you prevent that vomiting, but you are delivering fluid to that baby that will then be absorbed. And you are not going to have to struggle to get an IV line into a dehydrated baby, which is very, very difficult. You would then supplement with zinc and with the vitamin A, and studies have shown that zinc and vitamin A decrease both the severity and the length of illness. Now, conventional wisdom is that you do not use lactose products. So you wouldn't give milk, you wouldn't give dairy products, because we know that the diarrheal process destroys the lactase enzyme in the gut, and therefore those foods will not be properly absorbed. And by continuing to give them, you are propagating that lack of lactase, and the diarrhea will continue. However, you do need to be practical and pragmatic, and you will find that in a lot of cases, it is important to get nutrition into the child, and is very dependent on what is available in the household. So, when you correct dehydration, start with mild dehydration. You would give oral fluids freely, you'd encourage normal feeding, and you would give breast milk, you would give citrus juices, you would give rehydration fluids, and or water. And mild dehydration, often you can get away with just giving water breast milk, and fruit juices. Now, if you have 5 to 10% of body weight loss, you might want to make sure that you're replacing electrolytes as well, because those are being lost. And you would give an oral rehydration fluid. So you would give fluid as you would normally, and then you would give additional fluid after each bowel action, approximately the amount that is being lost. So, what is oral rehydration fluid and how does it work? So the principle behind it is that you put glucose and sodium into your fluid. These are actively transported from the gut into the cell, and they maintain electrical neutrality, allowing chloride to be absorbed passively. And because you've got osmotic neutrality, the water is absorbed passively into the fluid, and therefore you're rehydrating. So what do you use? And there are a number of different recipes. You have a WHO UNICEF one, the second version of that, and you have Diarrhea. Now, you will notice that these are exactly the same except for the sodium content. The original recipe had quite high sodium content, and subsequently both Diarrhea and the second UNICEF WHO one has got a much lower sodium content. And the reason for this, again, is that looking at children who've needed to be rehydrated, they actually do much better with a lower sodium content in their oral rehydration fluid. So, We have fewer unscheduled uses of IV infusions, lower stool volumes, and less vomiting, as well as a decreased cost, which is important when you're looking at a population-based economics. I'm not going to go through that, but you will have that with you. That is how to make oral rehydration fluid at home, which is really important for parents. They don't need to have diarrhea sachets, they can make it themselves. So let's look at nutrition. Now, when you put food into a gut, you have the gastrocolic reflex. When you take food in orally, you have waves of contraction which pass down the gut. You then have a bowel action. So the common practice in diarrheal disease is to starve patients, because if you put nothing in the top end, nothing is going to come out the bottom end. And parents are happy because they think that actually the children are getting better. But that's not the way to do it, because what happens is that it decreases enzyme expression on the brushboard of the gut and therefore decreases the ability of the gut to function, and it has longer-term consequences for digestion, for absorption, and for nutrition. You give zinc supplements, you feed your child as soon as they want to eat, and until then you give fluids. You want to consistently assess for dehydration. If the diarrhea is continuing beyond when you think it should, you need to look for other causes. So you'd look for worms and parasites. You look for evidence of infection outside the gut. And you would do this only after you have a lack of response of your diarrhea, and your diarrhea has been going on for longer than 14 days, which is the definition of prolonged diarrhea. And you'd look for things like TB and HIV and recent measles, all of which can affect the gut as well as elsewhere in the body. If there's blood in the stools, you want to treat for Shigella, Campylobacter, Salmonella, all of which can be treated using ciprofloxacin or another fluoroquinolone, or you could use azithromycin. Nutrition, you want to make sure that you've maximized your trace elements, your folic acid and your zinc. And only then would you start to look for non-infectious causes of diarrhea. I'm going to shift and talk about the third group of infectious pathogens that can cause diarrhea. And an example of this, of parasites, is Giardia, which is a single-cell protozoan parasite. It causes watery small bowel diarrhea. It interferes with absorption. It causes low lactase level, chronic diarrhea. So if you have persistent diarrhea, this is one to look at. And it causes weight loss and bloating. You'd look in the stool, you'd find cysts, and occasionally you'd find trophozoites. And the treatment is simple. It's tinidazole, 2 grams. So if you think that the symptoms and signs clinically are consistent with Giardia, you've had persistent diarrhea, but you can't actually test for it, it might be worth treating with tinidazole. Finally, let's talk a little bit about worms. Now, worms are important because they can cause long-term effects. We know that they cause persistent diarrhea with blood in the stools because they use the nutrition of the child. They therefore can cause undernutrition and malnutrition. And from this study from a colleague of mine in Jamaica, which was done a number of years ago, he showed that after treatment, children got taller and heavier because their nutrition was going to them rather than their worms, and they were no longer inflamed. Inflammation both increases your metabolic requirement at the same time as the worms are sucking out the nutrition. So you have a double whammy there with 2 reasons why malnutrition can occur. Now let's look at amoebic dysentery, which is again a parasite, but a cause of colitis, so large bowel disease. And here you get a persistent change in bowel habit, which can be mild to severe. You get blood on or in the stool, you get blood-stained mucus, and the severity of your diarrhea is related to the extent of the colitis, so that the amount of blood and mucus in your stool and the amount of the gut that has been inflamed and damaged. And if you were to look at the gut, you'd find that it's ulcerated and bleeding. Again, you would treat with metronidazole and tinidazole. Now, we need to think about the sequelae of diarrheal disease for children. Malnutrition is a big problem. There is temporary immunocompromise, which means you can get into a cycle of recurrent infections, which can then continue to cause immunocompromise. And vulnerability to a secondary infection, which is often bacterial. And you then get an increased susceptibility to diarrheal disease, so you can get this continuing cycle of illness one after the other. And longer term, because of the loss of nutrition, you get growth stunting, and it also affects your ability to think and your ability to develop cognitively. Now, the spread of disease is fecal-oral. It's through contaminated food, contaminated water, and poor hygiene. So 90% of diarrhea can be prevented if our water is safe, if we have good sanitation, good hygiene, and good nutrition. So it's quite sobering for us as medics to realize that public health and sanitation engineers are far more important in preventing this and decreasing disease than we as clinicians are. And children only come to us with disease once there has been failure here. Quickly, I realize I'm a couple of minutes over. I'm going to talk quickly about vaccinations, as these are very important preventive modality. And the two that we have are rotavirus and cholera, as I talked about right at the very beginning. Now, rotavirus vaccines have been part of the routine primary immunization schedule across the world for a couple of decades now. We have a number of different types. We have human monovalent vaccines, bovine vaccines, and we did have rhesus vaccines. They are vaccines which contain the most important phenotypes and genotypes of that cause disease, and have been extensively tested in different parts of the world. They have decreased the amount of disease and the amount of morbidity caused by disease enormously. So when we think about interventions to decrease morbidity and mortality, we're talking about improved water quality, sanitation, hand washing, zinc supplementation, rotavirus vaccine, and only then would we need health workers and home visits and community centres providing oral rehydration fluid. And finally, if nothing else works, lactose-free diet. So thank you all. I'm happy to answer any questions. I realize that was a rather whistle-stop tour through bowel infections in children. So feel free to ask any questions.
Thank you so much for that lecture. That was very informative and very helpful. Thank you. We did have a few questions. The first one was how do you differentiate between a severe viral diarrheal infection with a huge fluid loss from cholera infection, and is it because cholera is painless?
Okay, that's a really important question, and I'm glad that it was asked, so thank you for that. It is not so much the diarrhea itself. They're both small bowel diarrheas, and they both are painless. So the way you would differentiate really is very dependent on where you are, and it's about thinking through what is most likely in the setting that you're in. So if you are in a setting which is a refugee camp, a setting where you have poor sanitation, where you have overcrowding, where you are in a trauma or war setting, then it's really important to think about cholera, because it is a signal that you've got a problem. If you're seeing the first case, then you want to sound the alarm so that you can look at what is broken and fix it so it doesn't spread, because it spreads very quickly. Now, that is a very different scenario. You would get, clinically, you'd get diarrhea, large volume diarrhea. You would get a fever. But you also would get large volume diarrhea and fever in a child with rotavirus. But if you have a child who is in a city and it's winter or early spring and they are in nursery and there are a few other children who've had it and everybody else as well, it's more likely that it's going to be rotavirus. So you need to look at the setting in which you are working and in which your patient is presenting to see what the most likely causes are. Now, they're both, cholera is much more likely to occur as part of an outbreak, so you are likely to see a number of cases at the same time in those sorts of settings. Rotavirus, again, you think about the time of year and the age group of child, and it does spread, but it also has a very distinctive smell to it. So those are the ways that you would differentiate the two. I hope that answers the question.
Yes, it does. Thank you. And the next question was, until what age can we see the big fontanelle in children?
At least until a year, and that gradually closes by 18 months. So it's most useful in the first 6 to 9 months of life.
Thank you. Until what percentage of dehydration can a child die?
I think if you think of the cascade of, rather than thinking percentage dehydration, you need to think about the clinical symptoms. So you need to be really concerned about a child who is too lethargic to drink, who's very tired and not responsive, and a child whose heart rate is high. Because once they get to that point, they are at risk of dying. Because children tend to be very active and very busy and run around. So the more lethargic they are, the greater the danger sign that they are unwell and becoming less well. And we know that hypovolemia, low blood pressure, is the last sign that we see in the process. And children are very good at keeping their heart rates up very well for a long, long time, even when they're quite badly dehydrated. So if their heart rates are high, you know that you're in trouble. And if their heart rates are high and their blood pressures are starting to drop, then they are in danger of dying. You want to get to them long before that. You want to get to them when they're a bit irritable, a bit restless, and are very thirsty and really want to drink, because then that's fantastic. You can just get fluid into them and let them drink as much as they want, and that will rehydrate them. For those that are in that sort of situation and who are vomiting, you would want in the first instance to pass an NG tube. And the reason I say that is because it's a relatively safe procedure. You bypass the gag reflex. You can get fluid in very reliably with that we know will be absorbed just as drinking would, and it is much less difficult than trying to put an IV line into a child who's dehydrated. Putting up IV lines is complicated in children at the best of times, but when their veins are collapsed because they're so dehydrated, it becomes even more of a problem. And then you need to think about putting in your sorry, I'm having a senior moment. Your bone lines, your osteo, lines.
You're talking about IOs?
Yes, I'm talking about IOs. Thank you. I was having a moment.
Thank you. The next question was, could you explain the mechanism of zinc?
I was hoping somebody wouldn't ask me that question. We're not entirely sure what the mechanism is. We just know that giving zinc increases the rate at which children recover. And it also has an immune modulatory effect in that if you are zinc deficient, you are more immune compromised.
Thank you. I had a question myself. When you mentioned that if a child has experienced diarrhea, not to give them lactose free. If a child is like a really small child, like a baby and everything, and they're not weaned onto like food and everything, would feeding tube be like the replacement in order to?
You can give food, you can give fluids orally. For a baby who's not yet weaned on solids, they're either having breast milk or they're having formula feeds. So if they're having breast milk, that really is the best possible fluid to give them, because we know it's absorbed beautifully, it doesn't cause any inflammation, and is not going to exacerbate diarrhea. If they're on formula food, then you have a decision to make, because it is a balance between that child becoming malnourished through a lack of nutrients by not getting formula food versus the persistence of diarrhea because of a lack of lactase enzyme in the gut. And I think that you need to err on the side of providing nutrition and therefore give formula. If they are not taking it orally, then absolutely an NG tube.
Okay, thank you. The next question was, are cholera and rotavirus vaccinations effective for life?
Rotavirus tends to be a disease of young children, which is why it's given as part of the primary routine schedule. And it covers children for the first 5 years of life, which is the important period. Later on, an adult might get a little bit of diarrhea, but it's insignificant. So essentially, rotavirus covers the most important period of life. Cholera is about 10 years.
Thank you. Is it possible to develop immunity against cholera and rotavirus? And then there's a follow-on question of how you can tell the difference between watery diarrhea, fatty diarrhea, and inflammatory diarrhea.
Okay. Let's start with immunity. Absolutely. There is a degree of immunity to rotavirus. However, because it's not a virus that is circulated in the bloodstream, you're talking about surface immunity to rotavirus, which is not particularly long-lasting. So you will get a degree of that, but you won't get robust antibodies to it in the majority of cases. And it's similar for cholera. Second question, differentiation between different types of diarrhea. It's quite simple. If you go back to the first few slides that I showed, if you have a large volume non-bloody diarrhea, that is small bowel disease and is most likely to be viral. If you have bloody diarrhea with mucus and pain that is a smaller volume, then you have an inflammatory large bowel disease. So it's opposites. Large volume, small bowel, small volume, bloody is large bowel disease.
Thank you. Got a question. Could you please explain the mechanism of probiotics in diarrhea?
Okay. Probiotics are something that we don't talk a great deal about as medics, and we probably should. Everybody's gut is populated with bacteria, and it's a whole little zoo in there. It's a whole community of saprophytic bacteria throughout our guts, which are healthy. So we talk about the microbiome. A healthy microbiome. Now, when you have diarrhea, some of that is washed away and is destroyed, and when you add antibiotics to the mix, that is upset, and you have an overgrowth of some and a destruction of others as part of the process of destroying your pathogen, and therefore you can have persistence of your diarrhea. So what you want to do, and what the object of using probiotics is that you are rebalancing your microbiome with your healthy bacterial community.
Thank you. And the last question is, how can you distinguish between community-acquired infectious disease and hospital-acquired infectious disease?
Okay, that is a very, very big subject, and I'm happy to give a whole lecture on that. But, it's really thinking about firstly having good infection control in your hospital. So when you have an infection, you can identify it. You can identify when a child comes in with an infection versus a child who gets infection on the ward. So at the most basic level, that's what it is. The majority of infections don't see the inside of hospitals, so they are by definition going to be community acquired. And those that do see a hospital, if they occur greater than sort of 2 to 3 days after admission, with symptoms that are new since admission, you need to think about a hospital-acquired infection. So, for example, if we use the example of norovirus, which goes through hospitals, a child who's been on a ward for a couple of weeks, who's been fine, who suddenly gets rip-roaring diarrhea, either has that due to medication that's been given or is likely to have picked up a hospital infection. But it's about infection control.
Thank you. And one final question, which I did miss. Is it okay to deworm even if you feel healthy? And what are the medications to deworm?
Completely. And in fact, if you look at WHO guidelines and you look at national guidelines and programs across the world for care of the under fives, deworming is part of the routine schedule, and children get dewormed twice a year, and they use something like Vermox. It depends on what's available in whichever country, but it is a really good thing to do. And in most of Africa and Asia, certainly it's part of the routine schedule, just as you would get your immunizations.
Great, thank you. Thank you much for your time, Doctor. Really appreciate you taking the time and giving us such an informative lecture. Yes, thank you. Everyone, I've shared the feedback form in the chat. Please make a note of it. I'll keep the call open for the next 30 seconds or so. And we do have another lecture at 11. So I'll end the call and everyone please rejoin. Thank you.
Thanks a lot. Bye.
Bye-bye.